Welcome everybody to this section number 132, patient decision-making in low-risk papillary thyroid cancer, including active surveillance. I'm Roberta Perry, and I will be the host of this session. And I'm a longtime ThyCa volunteer, and I have the privilege of introducing our speakers today. Dr. Drs Davies is an associate professor of surgery at Dartmouth Institute Veterans Affairs Medical Center in White River Junction, Vermont. She also serves as chief of otolaryngology, head and neck surgery. Dr. Davies spent the 2017-18 academic year as a Fulbright Global Scholar grantee, traveling to Japan and England to do research on thyroid cancer and gain expertise in surgical, clinical trial design and implementation. She is best known for her work to define and mitigate the problem of overdiagnosis in thyroid cancer. She is the subject matter expert reviewer for the U.S. Preventive Services Task Force on Thyroid Cancer Screening on the Task Force for International Agency of Research on Cancer, Lyon, France, to make recommendations about thyroid monitoring after nuclear accidents, and as an advisor to the state of North Carolina on thyroid cancer cluster evaluation. Dr. Anna Sawka is a clinician, scientist, and endocrinologist at Toronto General Hospital Research Institute in Toronto, Canada. Dr. Sawka was recently promoted to professor of the Division of Endocrinology, Department of Medicine at the University of Toronto. She holds a PhD in health research methodology, biostatistics, and epidemiology from McMaster University. Her research focuses primarily on thyroid cancer. Dr. Michael Tuttle is an endocrinologist at Memorial Sloan Kettering Cancer Center in New York, New York. Dr. Tuttle is also a professor of medicine at the Joan and Sanford I. Weill Medical College of Cornell University. Dr. Tuttle's research projects in radiation-induced thyroid cancer have taken him from Kwajalein Atoll in the Marshall Islands to Hanford Nuclear Power Plant in Washington State, to regions in Russia that were exposed to fallout from Chernobyl accident. He served on the American Thyroid Association committee that produces the current guidelines for the management of benign and malignant thyroid nodules. He also chaired the National Comprehensive Cancer Network Thyroid Cancer Panel and served on the endocrinologic and metabolic drug advisory committee for the U.S. Food and Drug Administration. Dr. Tuttle is a ThyCa medical advisor. So now I will turn it over to our lovely presenters.
Okay. Should I start? I'll start then. I think we had the slides. Great. Well, first of all, thank you for inviting me. This is a real pleasure being with these speakers as well. And we've been tasked with discussing patient decision-making in low-risk thyroid cancer, including active surveillance. We really don't have much in the way of slides. So I think Dr. Tuttle and Dr. Davies were planning more of an interactive thing, but I wanted to just kind of give a little bit of framework. So we're really talking about small, low-risk differentiated thyroid cancer, which is confined to the thyroid. So this is without any lymph node metastases or spread outside the thyroid. Typically, one would detect this on some form of imaging, such as an ultrasound or CT scan leading to an ultrasound, but ultimately ultrasound is sort of the imaging pathway of choice. Then leading to, if the nodule meets certain indications as per guidelines, a biopsy, which is generally done under ultrasound guidance. And in terms of the biopsy, this has been a moving target, so to speak, in that guidelines have changed and they've evolved. And as technology has evolved, we've been able to biopsy smaller and smaller nodules. But then we've come to realize, well, maybe this isn't such a good thing to be biopsying these tiny nodules if we're subjecting people to surgery or other procedures that can also be subject to harm if there's unclear benefit. And typically in the case of a biopsy that's suspicious or positive for papillary thyroid cancer, this has traditionally led to thyroidectomy. That may be a partial thyroidectomy where half or a little more than half of the thyroid is removed, or a total thyroidectomy, in which case the patient needs to go on lifelong thyroid medicine. And sometimes, depending on the risk level of that thyroid cancer, there may be radioactive iodine, oral radioactive iodine treatment in addition to the after a total thyroidectomy. So what we're really talking about here is, kind of looking at more so here the question of, do you always have to do a thyroidectomy in these cases? I think in some cases, and Mike has experience with this, you don't always necessarily have to do a biopsy either, but this is really kind of the main focus with active surveillance. And the fundamental components of active surveillance is really avoiding or deferring the initial treatment, which is surgery to remove the thyroid for a small thyroid cancer localized in the thyroid that's not, that has some additional low risk features, which I won't get into a lot of detail, but essentially the location can't be threatening critical structures like trachea or the nerve, recurrent laryngeal nerve. So there are some special sort of criteria for who would qualify, but initially these patients are given the opportunity to avoid having their thyroid removed. But it doesn't mean doing nothing, and it is an active approach. What it does mean is that the patient agrees and the physician agrees to closely monitor the disease. And this includes clinical assessments, diagnostic tests, which is in this case, the most important of which is neck ultrasound to track the nodule and look for lymph nodes. Sometimes there may be some blood work, but really the mainstay is actually ultrasound in the context of thyroid cancer. That is different for different diseases. For example, in prostate cancer, that may involve serial biopsies, which we don't do. And the other thing that's very important to realize in active surveillance is we don't just follow it indefinitely with no goals. There's a specific protocol, and if the disease progresses, for example, the nodule grows by a certain amount, or there's lymph node metastases that are seen on ultrasound, then the idea is that one would do, Dr. Miyachi's referred to salvage therapy or salvage surgery, but what it means is that patient would have a surgery with an intent of curing that cancer. So this is not palliation. So in small, low risk papillary thyroid cancer, this means the patient may initially avoid thyroidectomy, would be monitored clinically and by ultrasound. But again, if that tumor grows or metastasizes, the idea is that curative intent surgery would be performed. And again, you need that close monitoring to make sure that you're intervening at a point where it can be still curative. Dr. Tuttle's group has done extensive research in active surveillance and really was the first group that, Louise has also done research, but I've quoted one of Mike's studies here. And he looked at why patients chose active surveillance at Memorial Sloan Kettering. And so the patients choosing active surveillance viewed papillary thyroid cancer as very common, indolent, or non-threatening, and they felt it was low risk. However, they were concerned about removing the thyroid and the possibility of going on thyroid hormone for the rest of their life. The other thing is that they were open to reconsidering surgery in the future. As you know, if you have surgery, you can't go back and put in the thyroid back again. I have been asked that question, actually. But if you choose not to have surgery, you can always change your mind, even if the disease does not progress. And some patients do that. The other thing that's important to know, and this is from a patient of mine, that active surveillance is really a choice. It's a choice made by the patient with their doctor. It's not giving up. It's not denial. It's not neglect. And it's not stupid or crazy. And I know Louise has published on this as well. So I think that's something that a patient of mine really wanted to convey, who is under active surveillance, and I wanted to share that with the group. And that's really all the formal slide presentation that I have.
Dr. Davies.
That's a perfect place to start. I love that.
So comments, Louise, what were you thinking here?
I love the way, Anna, how you so clearly describe that active surveillance is a decision that you make together and that you do together. And that it doesn't mean that you're doing nothing and that nothing happens if the cancer changes. I actually like it. It's funny, the term that I've heard Dr. Biopsy use is rescue surgery, which always makes it feel very dramatic. And I actually think it might be better just to say, actually, we decide we have to change treatment. We change treatment from monitoring to doing the surgery, because it's not like we're having to chase after something that has escaped us, and it's a highly unlikely that we'll be successful. That the rates of success are really good. So yeah, but that is really excellent. I love that slide. Not stupid and not crazy. Very reasonable, actually.
We get that a lot because they're told it's stupid and crazy. Just to the audience, feel free to put questions in the chat or in the Q&A. Roberta and Abby will look at this. Anna, let me ask you to start with. The whole premise is we're talking about low-risk thyroid cancer. If somebody asks you what low-risk really meant, I mean, what's the risk for what, and how should my mom think about when you say low risk? What's in your head you're trying to convey to her?
Yes, well, I think that, clearly you are the world's expert in this area of risk stratification in your research and guidelines work, Mike. So hats off to you. But I think that I've actually used the term for the context of active surveillance of even very low risk, because when we think of low risk, we think of low risk with treatment of dying of disease or low risk of the disease coming back. So that assumes you've removed the cancer by surgery plus or minus radioiodine, and there's a low chance that that cancer is going to come back. If it does come back, it's more likely to come back in the neck than distant metastases with these types of tumors. But again, there's a low risk of that. So typically people say 2 or 3% over the course of 5 years or so for recurrence, and mortality is, close to 0%. So that's low risk, but very low risk is actually, you have to think about it even more carefully with active surveillance, because we're leaving that cancer in place. So what we want is small tumors, the tumors that Dr. Miyachi has studied is up to a centimeter. You've studied, I believe, up to 1.5 centimeters. And so this is, where we kind of, make that endpoint, I think, is still in flux because research is ongoing. But basically, these are small tumors. The other thing is that there's no evidence. You have to scrutinize them so carefully in terms of their location. Are they near the nerve that controls the vocal cords, the recurrent laryngeal nerve? Are they essentially abutting the trachea, the windpipe, in a way that they could invade the trachea? Is there any hint that this tumor may be starting to sort of bulge out of the thyroids, what we call extrathyroidal extension? So you have to scrutinize these little tumors very, very well. The other thing is that you have to really be sure that on imaging, there's no evidence of any lymph nodes. So for these very low risk patients, this would be typically a small tumor. The cytology would be papillary or suspicious for papillary, so not other types of thyroid cancer. And again, in a location where it's amenable to active surveillance, in that you've got a little room where that if that tumor were to grow, it's not going to imminently threaten structures. And of course, you've written extensively on this and given us guidance on that, Mike.
Those are awesome. Louise, I often hear you use the term active monitoring instead of active surveillance. Can you say that's different wording than sometimes we think about? Can you talk about that?
Yeah, it is. It's interesting. I'm glad you asked. So this is active monitoring is actually the term that they use now for prostate cancer. So active surveillance was first proposed, as far as I know, for prostate cancer, and the trials showing that was safe were published back in 2016. Interestingly, prostate cancer is actually much more deadly than low-risk thyroid cancer is, but there are some low-risk tumors. And what they found in talking to patients was that active surveillance felt like people spying or felt sort of dangerous. And so they use the term active monitoring. And in our most recent research that we had published with our friends from Kuma Hospital in Japan, and also based on input from the Sloan Kettering experience, we actually think that's an approach that we should adopt here, to call it active monitoring. And in our most recent paper, we actually even talked about the sort of what that relationship is. And we can talk about that now or later, but that's an interesting place to go too.
Yeah, go ahead and talk, because there's a couple of questions coming. Go ahead and talk about the guy, that decision model.
Yeah, so you know, when we think about the physician-patient relationship, and especially in cancer care, we often think about a relationship where the doctor's really giving advice, and then the patient either decides to take it or decides to go somewhere else. I mean, I feel like from my prior research, that's kind of the experience for a cancer patient. There's another model that's out there called shared decision-making. It's actually a great model when you're thinking about whether you want to get a knee replacement or whether you want to have one particular approach over another to a cancer or a disease where there are actually lots of different approaches. This model that we feel like is unique for this is what we call the guide model. And it's the idea that actually you and the patient together, I'm the clinician in this case, decide together that you're going to travel a particular path, and it carries a small amount of risk for both of you. You know, if you were going on a trip, like if you're like me, you live in a rural area, you think about hiking or mountain climbing. If you're a person who likes to travel, you've got your tour guide. They've been on that route before. They kind of know where the pitfalls are. They can help you understand what the issues are likely to be. And then you decide together that you think that's a good route to travel. And as you travel that path together, your clinician, your guide, will direct you in the best way possible. And they might lay out some options, but they'll say, I think probably this is the right option. And you go together and you take on those risks together. And if you can see together that actually things are changing and you should change your route, you do it together. So it's collaborative sharing of risks and concerns and the anxiety that we might all naturally feel, but by doing it together and knowing that we're sharing all the data and we're sharing all the information, then it can really become a true supportive relationship in both directions. You know, you as the clinician know your patient's going to come back, and as the patient, you know that your clinician is not going to leave you behind, and also not going to put you in a situation where you're ever unsafe.
And Anna,
can I ask something,
Go ahead,
guys?
Abby.
Yeah, I was just, so you're saying, I like that shared decision-making model, but shouldn't, in theory, shouldn't an active surveillance model turn into that?
Well,
in
this
theory?
is like totally getting into the weeds of like people who think about decision making all the time. So in actuality, the shared decision making model was intended to be for decisions where there are two good options and actually only the patient can decide.
Oh.
And this model is really about, it's not about a discrete point in time. So shared decision making is like deciding to get a knee replacement or not, for instance. But this is really about a long-term relationship where every visit is a reevaluation of what do we think now, how are we going to go now? And shared decision-making principles certainly apply here, right? You're going to decide together to do it, but it's getting into the weeds of the people who think about this sort of thing on a theoretical level. But so you're right, it implies, it incorporates the shared decision-making principles, but it also carries it through realizing that it's an ongoing relationship. It's not a discrete point in time. Does that help?
Yeah, thanks for that. If you don't mind, I noticed there are a bunch of questions in the Q&A, so I don't know if can you see them or should we read them to you?
I can see them, so let me go through them. Anna, let me start with you. One of them has to ask this whole issue of do you need to biopsy things that are low risk on the ultrasound? And you know, a question we get in clinic all the time, is there any harm in doing a biopsy, even if the ultrasound says it's low risk on the ultrasound? Any harm? Why not just biopsy all of them?
Well, basically, I guess the question is, we used to almost do that with biopsy thresholds down to like 5 millimeters, I think was the smallest I've seen. And so the harm is physical harm, I think, is relatively small. I've not seen terrible complications with the actual procedure. Sometimes you do end up with non-diagnostic or indeterminate biopsies, and patients may end up actually even having surgery because of these issues. So sometimes you can do harm in that you actually can't get a definitive answer, and then you sort of go down the pathway of doing surgery. And certainly I think all of us have had patients who've had surgery and then there was no cancer there. So, it's you can do harm in that way. The other thing is that, diagnosing something that's very small, I think you really have to have a conversation with the patient as well, obviously, because this is different for different people. But you can continue to monitor very small nodules without a biopsy. And that's kind of the way the American Thyroid Association guidelines have gone. So you're essentially doing almost an active monitoring, but without a biopsy. And then you're not labeling that individual with the diagnosis of cancer, which is life-changing and has implications for insurance and other sort of facets of life. So the harm of biopsy can be, you have to think beyond the physical, and also what are the downstream implications of the result, as well as including the psychosocial kind of implications. So that would be my kind of answer to question of harm.
Yeah. So there's a couple different sets of questions. Louise, I'll ask you what are the indications to stop active monitoring? Like when is sort of a hard
when do we stop?
Yeah. And then after she does that, Anna, then if the hard stop is because there's a lymph node metastasis, what does that mean? Does that change the outcome? Oh my God. So Louise first, when's that transition from monitoring to not monitoring?
Well, here I'm going to actually, say out loud the things that actually Dr. Tuttle has published on. But let's see if I can recite it correctly, and then you can add if you have details to add. That will be helpful. So the things that I think about, the things that I think about are if the tumor volume overall doubles, or if you're a person who likes to only rely on one measurement. If it increases by about 3 millimeters in size, then we say, okay, we should think about whether maybe we should change treatment. If we see that it's having a trajectory where we're kind of watching it grow, it's teeny weeny, like let's say we started with a 5 millimeter one just by chance, because that's kind of the way our care unfolded, and we see a trajectory that looks like it's changing a lot, that would be a reason to think about a change. If it looks like it's starting to kind of get a little bit closer than we'd like to where the recurrent nerve passes, the one thing that Anna was describing that makes the nerve to the voice box go, that's a reason to think about changing treatment. If it kind of looks like it's maybe starting to get outside the thyroid capsule or kind of a little bit closer to the edge where it might go into other places, that's a good reason to switch. And of course, the last thing that Anna's going to talk about a little bit more is if you see that actually it looks like it's set up shop in a lymph node nearby, that the cancer has spread to a nearby lymph node, then that means it's time to really think about a different approach.
Anna?
Just to add to that, Louise, I know you've written on this is in terms of crossing over, we kind of use the term crossover to surgery. You can change your mind. So as we said, so an indication is it hasn't grown, patient doesn't want to continue this, that's okay. So I know we all agree on that.
And we've also had, it's interesting, I've had some issues come up where it's not even just you change your mind, but actually the health indications change. So like in the veterans system, I've had people tell me they had to have surgery because they wouldn't be allowed to deploy, even though it was a tiny cancer. So they had to have surgery. Wow. Yeah. And then if people have like issues with their kidneys, this would be pretty unusual, but sometimes if you're being faced with a possibility of a transplant, they won't let you have a cancer that you monitor in that setting either. So those are like some unusual, but other health reasons besides, I just don't want to watch it anymore, which is also reasonable.
So if it spreads to the lymph nodes, Anna, I mean, we always say no big deal, but if it's you and it spreads to the lymph nodes while we've been watching, do you really worry more about that? Do you wish you never watched to begin with? I mean, how do you sort of frame that for the patients?
Yeah. So first of all, of course, you want to be sure that if you're seeing, again, you're monitoring patients are very quick, very often. So we do every 6 months for 2 years. You do it sooner if there's something that you're kind of not sure about, and then yearly. So if you do see a lymph node, the first thing is you make sure that it's not something else. Sometimes someone could have a reactive lymph node, so it's not necessarily suspicious. But assuming, this is a suspicious lymph node, and it's a lymph node that, is sizable enough that you could biopsy, because you can also see very, very tiny things that it would be very challenging to sort of get at. You do a biopsy. So find out if it's positive. Now, when we monitor for active surveillance, we use ultrasound. That's the standard. You're not going to see the lymph nodes that may be behind the thyroid. And so that's kind of a whole different area that even with low risk patients, they may have tiny lymph nodes behind the thyroid. What you're biopsying is typically a lymph node that is not behind the thyroid. And then you really, at that point, are committed to surgery. Depending on the surgical findings, so what you would do is clear out whatever would be the appropriate amount of thyroid tissue, usually with a lateral neck lymph node, that would be a total thyroidectomy. And again, you would then see what the pathology shows. You would clear out any obvious sort of disease, and plus or minus radioiodine, depending on risk. A lot of times what we'll do as well, in addition, when this lymph node business comes up, is do a CT of the neck, because you can see whether there's more enhancement in other nodes, including some of those ones I mentioned that are behind the thyroid that just the ultrasound often will not capture. So we also then really kind of take another look with other imaging. And, the reality is that, the experience with these lymph nodes, I mean, it's very uncommon. If you actually look at the meta-analysis by Cho et al., I think it was 1.5% of all patients who underwent active surveillance. These are 1.5 centimeter or less primary tumors, carefully selected. So very important to note, and your data was included with that, Mike. The overall average for the percentage of patients who got lymph node metastases was 1.5%. Now, if you actually look at Dr. Miyachi's data on surgically treated patients, it's about the same. So it's kind of curious. We don't have necessarily, clear head-to-head comparison, but if you do an indirect comparison, it's actually comparable. And those patients can be cured and are cured with surgery in the current published experience.
Yeah, those are great. Louise, there's a couple questions on here that I'll frame it. They ask it nicer than this, but they're like, okay, we love our tour guide, but I don't want to live with him the rest of my life. When can I get rid of my tour guide? So the questions were, when can I stop doing follow-up, right? So my question to you is, when can I get rid of my tour guide?
I think this is an excellent question, and we don't know the answer yet. This is research that we still need to develop. We call this the off-ramp, like, where's the off-ramp, please? Yep. And I think this is work that we'll have to do going forward as a field. From a practical standpoint, while we're waiting for data to accumulate, I think it probably depends on what decade of age you are, right? So if you're in your 20s, 30s, 40s, you're probably looking at definitely 5 to 10 years of annual ultrasounds. But if you're already doing breast mammography or other screening type tests, it would be kind of like doing that. If you're in your 50s, 60s, 70s, maybe after 3 to 5 years, if it's really not changing, maybe you don't need to be looking so often. And I have to say, so I work primarily with an older veteran population. And my rule of thumb thus far has been, if we look once a year for 2 years or 3 years, depending on what you want, how closely you want to look, and we haven't seen anything, then let's wait 2 years. Then that brings us out to 5 years, and then let's decide whether we're ever going to look again. So I don't know. What are you doing, Mike?
It's the perfect question. I had this exact discussion at noon. My last patient was somebody I've been following for 5 years.
Yeah. 7
millimeters, 3 dimensions, haven't changed at all. And his question with a straight face is, do I ever need to see you again? And I said, well, A, that's a little hurtful, number one.
Yeah,
But
yeah, a little, you know.
number two, I have grandchildren that are expensive, so that goes into my decision. Yeah, and we agreed to do another ultrasound in 2 or 3 years. He was in his mid-50s or something.
Yeah.
So I think trying to figure out what that looks like over time.
Yeah, I mean, one thing that's sort of exciting is some of the research that we're thinking of doing would actually model it so that maybe we don't have to wait 20 years for data. We can look at the data that we've accumulated and figure out what is a reasonable off-ramp protocol, essentially. Anna, what are you guys doing up in Toronto?
So we're on a research ethics board approved study. So that's important because there's a sort of a fixed protocol. And so really it's yearly, well, every 6 months for 2 years, and then yearly if everything is stable. And
Yeah,
there
what's
is no
your off-ramp? Like you have no
there is no
off-ramp?
off-ramp, but at the same time, if you really look at the data, Louise, if you look at that Cho meta-analysis, things don't really start to take off with size until about 2 or 3 years. So, you know, if you look at the first year, 0.5%, it's like 0.5%, and then it kind of comes up. The other thing that I think we're extra cautious about is we're including patients with larger tumors, so under 2 centimeters. So you actually, you do have to be more cautious when you're sort of raising that bar, potentially for risk. And the other thing is that some studies do not include patients with multifocal disease, so multiple nodules. Absolutely, we've seen patients where that primary tumor remains stable and then something else pops up. In these patients who have multiple small suspicious nodules, you don't necessarily biopsy all of them because they don't meet criteria for biopsy at the beginning. But I think that, so we're on the cautious side. We don't really have an off-ramp. I'll tell you, we had 2 off-ramps, or 3 off-ramps. One patient in their mid-80s was enrolled. Well, actually, he was referred for a thyroidectomy is the reality. The patient had multiple comorbidities, got pneumonia, like 3 CHF, congestive heart failure, numerous sort of problems, was in ICU, died 6 months later. So that's the off-ramp. That patient died with his thyroid cancer. The patient did not die from his thyroid cancer. So that's the ultimate, right? So you've died with the disease never really hurt you. So that we've had one patient, and again, we allowed that patient to go in the study. The patient was quite happy not to undergo surgery and really didn't need it because he was going to die 6 months later. Another off-ramp is, well, I guess the thing is, I had another patient, also elderly, sort of late 80s, and the patient had enrolled in active surveillance. And remember, you called it active monitoring, but the key is active, right? We're all using the term active. This patient had been hospitalized with a life-threatening, very serious medical condition, sustained severe morbidity because of that. And his goals of care changed. So given his quality of life, even if he had a cancer that grew, he wouldn't go for an operation. And he was even refusing, I had a long conversation with his family doctor, he was refusing other specialty workup and consults. And so his goals of care were not to cure a progressive small thyroid cancer. They were basically to have, quality of life, really thinking about quality of life, which would for a limited lifespan. And so that patient actively withdrew from the study and said, I don't want to be monitored anymore. So you do run into this with the elderly, these kind of where goals of care can change. The other off-ramp, of course, is, we have not really had, we've had pretty good sort of uptake of patients continuing, but again, I don't know whether patients will withdraw more with time. Maybe we do need to think about that, but I think we're just not ready because we're looking at larger patients with larger tumors. So we're going on the cautious side.
I guess, I would say to that, well, Roberta, do you want to go first? Do you have a comment or question first?
No.
Okay.
I'll
I was going to say, I have to say, so I'm from Vermont. This is a place where we are not joiners. We are not a high intensity part of the country. I don't think you have to be dying to think about having an off ramp, right? Like I actually think that even if that cancer grows and maybe you need a surgery or something, I don't think you should have to be dying to think about stopping. And it can be more than just a goals of care conversation, which tends to be something we do when people really have pretty clear boundaries around what's going to happen and how things are going to unfold over the next months to years. We spend a lot of time in that gray zone here where I work, where I call it more, what are the competing risks, right?
Yeah.
Like you have heart disease and you do have a pacemaker, for instance. What do we actually think is the importance of coming here for a doctor's visit versus getting to see your grandkids? And so I think it's important too to convey that that not having such close follow-up could also be okay. And actually, I think that's the point of the whole guide model, right? Like if you'll have a physician who has different opinions. I might meet a patient who is Canadian or who is more consistent with Anna's outline, and they say, Dr. Davies, I love your like, we live rurally and we're not joiners thing, but that's not really my style. And I would say, okay, well then we need to keep looking.
I think the difference, sorry.
Yeah.
Go ahead,
I
Anna.
think the difference is when you're doing an REB approved study with safety, you have to commit to the follow-up. Outside of practice, I think that, reality is a patient can withdraw from the study at any time, but I think it's kind of a different framework when you're doing it as a prospective study. I also think we just don't have enough, really the longest follow-up we have is from Japan. For the patients that we're studying up to 2 centimeters, there is no long-term follow-up data. So, we do have a bit more uncertainty. And I agree with your points. I wish I had more data to sort of guide when it's safe to do that off-ramp. I'll tell you from my experience, though, that especially dealing with younger patients, what we're talking about is people, that are really, in their 80s, I think right now, and 90s too, but I think the oldest we have is in their 80s. When you have a young patient or youngish, whatever, maybe I'm middle-aged, so maybe they're like my age, that's youngish enough. That patient.
And younger all the time.
Yeah, that patient, they, in all honesty, that conversation that you have, they're looking up, we have a patient portal, they're looking up their results before we have that conversation. They know their results, they want it. They've even sometimes asked for more frequent ultrasounds, especially when you switch to yearly. And I think for some I find with the younger patients, absolutely, they want it. And this off-ramp doesn't happen. The off-ramp in those circumstances is, I'm always thinking about this. I just want it out. The off-ramp is an operation. It's not usually stopping testing. That's my experience anyways,
Yeah.
All right, I'm gonna move us on. I used to tell people, don't worry, everything is going to be fine. You're going to be at my retirement party. And apparently that's not as reassuring as it used to be. So, I used to get a really happy look for that. And then now I get, so when are you retiring? So I got
You can't retire.
Yeah, that's what they say. So let's move on a little bit. So let's get out of the active surveillance. There's several questions in here that have to do with sort of minimalistic management, lobectomy or prophylactic neck dissection. We'll start with you, Louise. This says, I had a conservative lobectomy. How do I know that there's not cancer on the other side or cancer in the lymph nodes? Because I had the surgery at Memorial and those guys don't take out any lymph nodes. They just don't want to know. I put that in there. They're horrible guides. They're like, don't step over there. You don't want to know. Louise, what do you tell people after lobectomy?
Yeah, so yeah, I mean, it's actually possible that you could have a tiny cancer in the other side. We know actually that if you look closely enough, about 11% of people have a tiny cancer in their thyroid gland at the time they die, when they've actually died of something else. But that doesn't necessarily mean that it'll change. My guess is that if you had a lobectomy, it was because your surgeon looked and decided that the other side looked like it was safe to leave intact, with the goal, probably, I would hope, if they're anything like me, the intent was to avoid having you have to take thyroid medicine every day. And in terms of the lymph node question, the central lymph node. You want me to take that one on too?
You're the
So-
surgeon, so.
Yeah. Yeah. So it's so interesting, right? Because there was a time period where we thought we should be maybe thinking about doing prophylactic central neck dissections. And what that means for people is taking out the lymph nodes that are behind the thyroid gland, not the ones that are kind of out in the side and underneath the big muscle that runs down the side of your neck, but behind the thyroid that you really otherwise can't see or feel. And they found that doing that actually didn't change outcomes, meaning people sometimes still showed up a few years later with some cancer that had set up shop in the lymph nodes that were out farther in those side muscle, beneath the side muscles of the neck. And so there are side effects that come with removing those lymph nodes. You have to do a lot more manipulation of the nerve that goes to the voice box. And you have to be really clear that you found the parathyroid glands, which are these little tiny glands that maintain your calcium balance. And nobody's perfect at that. Even the people who do it all the time still miss some parathyroid glands, and there's always a small but real risk of injury to your nerve there. So we decided as a field, for the most part, prophylactic neck dissection central neck dissections is not adding much, and there isn't really a good reason to do it.
Yeah, and we keep watching. Anna, the next question had the next step. This person had a total thyroidectomy for what's apparently a low-risk thyroid cancer and was told not to have radioactive iodine. Their TG on thyroid hormone therapy is sort of hovering around 1, but it goes up and down. And the question is, is there a TG level that you would recommend having radioactive iodine up front, or how do you deal with that TG over time? So total thyroidectomy, no radioactive iodine, pretend the TSH is 0.5 and the thyroglobulin's kind of hovering around 1. How do you deal with that?
Well, I think the other thing that you mentioned something very important, Mike, is what is the TSH? Because I think your assumption is that it's 0.5. Where the most common scenario where I see sort of these fluctuating low-level thyroglobulins in patients who've had a total thyroidectomy is fluctuation in TSH. So what is how tightly is that thyroid hormone level controlled? It certainly doesn't need to be controlled to the point of thyroid hormone excess, but you want to be looking at it in that context, because most of the time that is the issue. I think the other thing is you can't just look at it as a TG. So TG is immensely helpful, but you want to look at, the whole big picture. So what was the stage of disease? What was this low, presumably this was low risk disease to start. But I would want to be sure about what was the initial pathology. And sometimes too, you look at the OR notes and, really it's not really a total thyroidectomy. Maybe it's a subtotal or a subtotal plus or something. So I have had that where patients have not necessarily had a complete thyroidectomy. Sometimes you can see that on ultrasound if there's a remaining remnant. So that's, and that may be okay. It's something you can monitor, but then you just realize that for that person, that TG is actually normal. So a TG of 1 in itself is not really, to me, that, worrisome. I would want to know the trend though as well. And you have to be super careful at looking at these trends, that you're looking at it with the same lab, because different labs measure it differently. So if you're measuring it in 2 different labs, you go one day to your lab near your house, another day at the lab at the hospital, they may be completely different numbers. But that's not a change in you. It's a difference in the way they measure it. And the other thing is thyroglobulin antibodies interfere. So I think there's a lot of different factors to consider. A TG of 1 in itself would not be alarming, but you have to look at it in context. I hope that's helpful.
That's awesome. Louise, I lied about no more active surveillance question. There was a question about active surveillance in PEDS patients. What about watching in kids? Can you, a word or two about that?
Yeah, we're not there yet. I think, we're learning a lot based on the screening data that's coming out of the Fukushima health screening management program. After the Fukushima Daiichi nuclear power plant accident, they embarked upon a large-scale screening program for the people who live in that area. It's interesting, the radiation exposures were actually like almost unmeasurable but because there was anxiousness about it, they did create a program, and we're finding out so much that can help us understand whether there's thyroid cancers in teenagers that are going to grow, not grow, how much they're going to grow, but we're not there yet. So if you have a small cancer and you're a teenager, or you're the parent of a teenager, I think right now we have to think about what is the best way to manage it. And it's not going to be active monitoring. It's going to be something surgical.
We're just not there yet.
Yeah.
There was a question in here. This is a question about having surgery, then having radioactive iodine. Looked like some lymph nodes were involved, papillary cancer, and the TG has been coming down over the years. It was like 11 a couple years ago. It was down to 3 now, trending all the time to decrease, no TG antibodies, and the ultrasound was clean. This is a good question, because you gave us most of the information we need. And this is under the category of we see this. These thyroid globulin numbers, it used to be years ago, it would drop 1 year and I would give another treatment, and then it would drop and I would give another treatment. And I dried out a lot of mouths from radioactive iodine. But now we know that in the absence of structural disease, these thyroid globulin numbers often decline, frequently don't nadir till at least 18 months, and then often will continue to go down over time. So that's certainly an interesting phenomenon. Anna, this has to do with sort of long-term follow-up. So this is the assumption somebody's 5 years down the road, post-thyroidectomy, no persistence, no recurrence. We're in this low-risk setting, so let's answer it for the low-risk patient. So a low-risk patient, I tell people 5 years down the road, because we have to do everything base 10, right? We have 5 fingers and 10 fingers.
Yeah.
If we had 6 fingers, guess when our survival rates would be? It'd be 6-year survival rates. So there's nothing magic about 5 and base 10. But a low-risk patient, Anna, that you followed for years, and now you're at that 5-year point, for example, no evidence of disease. What does your follow-up look like after that?
Well, it's interesting, Mike, because it'd be interesting to know in your areas how it works. The Cancer Care Ontario clinical pathway. So this is, I'm not involved in this pathway, but it's basically a group of experts that have made these sort of algorithms similar to NCCN. It's very much consensus based. And for this kind of scenario, it says, okay, you can dismiss them to family doctor. But the problem is that in real life, that a lot of primary care physicians are not necessarily comfortable taking over. I think the other thing that I sort of have an issue with sometimes, so I don't think there's anything wrong with dismissing patients to primary care follow-up. If you can sort of arrange that. There's also a transition clinic through one of our hospitals, but even with that, it's only a transition for a couple of years. But we're kind of lacking the infrastructure. You really have to make sure that the care can be safely transferred. The other thing that I run into, it's often at that point, not about the thyroid cancer, it's about the thyroid hormone management. And so that can be challenging. Certainly someone with hypoparathyroidism as well. There's another endocrine gland that's affected. And so I find that sometimes it's challenging to transfer people when we're having challenge controlling their thyroid medication. So I don't have the right answer. I have dismissed people to follow up with their primary care when primary care was able to do it. And that has worked. I have had patients where that's not always been possible, and I wish I had a better solution.
Yeah, agree. We're honestly, we're just now really thinking about that, if we're honest.
Yes.
We kept people forever, right? That was never a decision. So, but at the cancer center, our oncologists don't. The patient is given a little card that says, ask your internist to order these tests. And these are like bone marrow transplant and leukemia patients. And so with sort of we call it a passport that says, please have your doctors do this. This is what we expect to see. If it's outside those, come back to see us. And so we're kind of getting in that ballpark. Louise, let's take it up one more little notch. This has to do with ethanol ablation or neck dissection. So somebody presumably, let's say they haven't had a lateral neck dissection. They had their total thyroidectomy. This one's a 8 millimeter papillary cancer behind the right carotid. So this is probably real. They didn't make this up, right?
Yeah, I think so.
Congratulations, Anonymous. This is where these actually live. So 8 mm nodule behind the carotid. And the question is, do I really need a big neck dissection, or can we do an ethanol ablation, a thermal ablation? Where are we on those sort of new techniques now, Louise?
I mean, this is not, I would not profess to be an expert here, but, you know, these things like ethanol ablation and thermal ablation methods have been applied to lymph nodes that are out laterally, particularly ones that are difficult to get to otherwise. Some people will also monitor them to see if they grow and change over time. And rather than go after one or well, so I should say, you know, so you could go in and you could do a whole neck dissection, but the problem is that even the best surgeon doesn't get every single lymph node, and 5 years later you might have another one, and so then you're faced with going back and having another surgery, which is just tough on your neck tissues. It's a more complicated surgery, so it's something worth discussing. Do you go with a neck dissection now? Do you actually use one of these ethanol or radiofrequency ablation approaches? Do you monitor it for a while and see if other lymph nodes show up or whether that one stays stable? That's sort of like, it's an answer, non-answer, but.
No, that's the truth. You have to think
Yeah.
about it. I'm going to ask Anna one more question, then I'm going to come to Roberta and Abby to see what questions you guys have from listening to all this. Anna, here's a question about somebody that had a total thyroidectomy many years ago, 5 or 10 years ago. TSH is around 0.5. There's a couple nodules in the thyroid bed that are like this 5 to 8 millimeters, haven't changed in years. Should you biopsy? There's nothing suspicious. What do you do with these thyroid bed nodules that are so common?
So the first key is, thank you, Mike, that they are common. So, and for me, some patients, you just see them around the first couple of years of surgery. So you do see those where I think there were maybe a little remnant or a little bit of inflammation. If you have a really good radiologist, sometimes they can even kind of tell, like, this is avascular, like they'll even say this is fat. So it's, you know, you really don't worry about that. I think with the, I didn't see, did I miss a thyroglobulin? Did you tell me one or no? I don't see one.
I made it up. It's undetectable.
Oh, it's undetectable. Yes. So generally, if they're stable and small, I wouldn't biopsy. If they were changing, that's a different story. If thyroglobulin was changing, and keeping the TSH where it is, that's actually pretty good, like low normal or just, you know, right around the lower limit of normal. So I would say that's appropriate. I do tend to periodically check them with ultrasound, but at some point you do kind of reevaluate that and you kind of make it less and less often. But at the same time, I think often patients do worry about that a bit. And so I'm happy to sort of every few years check it for, but generally they don't become a major problem.
This falls under the general group of things. We differentiate detectable findings from actionable findings. So this is the detectable. I generally apologize. We had a really good ultrasonographer that found it. Because in the old days with my fingers, we would have never known about it. The whole visit would be about you and the kids and where you spent your vacation. Now the whole visit's me trying to convince you these 2 little teeny lymph nodes don't mean anything. Roberta or Abby, what did we miss, or questions you guys have?
I had one quick question, and I guess it goes into this future treatment as well. But I'm curious as to how things develop with like radiofrequency ablation, how that might change active monitoring, and how that might change, you know, treatments of these smaller cancers or lymph nodes that might be indeterminate.
Yeah, that's a really good question, Roberta. The sort of thermal ablation is what we call it, just ways to heat up essentially the end of a needle, whether it's radio frequency or microwave or laser ablation. There's a bunch of different techniques. It's been applied for many years in benign nodules, primarily in Italy and Europe. And in that setting, you're just trying to kill the middle half of the nodule. You don't have to kill the whole thing, just enough to make it shrink so that cosmetically it looks good. And now I'm writing a paper right now. There's been 1,500 patients published with papillary microcarcinomas destroyed with one of these thermal ablation techniques, primarily China, Japan, and Korea, but starting there. So there's no question people are going to soon have the option of destroying little small thyroid cancers. Right now, we're doing it under an IRB approved protocol, is because we think it's still kind of on that research thing. I think we have to be careful with that, because the last thing we want is like setting up one of these things at the mall and grabbing every 10th person that comes through. I could be phenomenally rich just doing ablations after ablations. At our place, the people that want to watch and active monitoring, they're totally happy with wanting to watch. The folks at our place that ask about these ablations are people that want to be treated. They want the cancer dead. They don't necessarily want the thyroid taken out. And they'll often ask us, can you just take out that nodule? So I think in the right setting, that those ablation techniques will be for the people that want a treatment. They're not interested in watching, or they're watching and it starts to grow. But I think we have to be a little careful, because this would be a slippery slope and we could get a lot of people over treated. So still research right now, but I told the second patient I saw this morning, right now I thought there were 2 right answers, watching or surgery. And in 2 or 3 years, I think there'll be 3 right answers, watching, surgery, or one of those ablation techniques, because it's going to be safe. It's going to work. It's just, we're not hardly there yet, but it's coming down the pipe.
That's
Just also want to make sure that we have about 4 minutes left.
Yeah, I just wanted to, there was a question in the chat, and I suppose this is for someone who has been, hasn't done anything, any surgery or anything, but the question was, is there harm in doing the biopsy if the risk is determined low on the ultrasound? And they also said that they were concerned, is there, I guess, any truth to the matter that, while you're taking the biopsy, will you cause, cells to flake off and then, cause major problems? Is that a possibility?
We get that question all the time. I tell them to phone a friend in Vermont. Vermont, what do you tell people? Dr. Davies?
Yes. So I believe the rate of, we call it needle implantation, like tract, is like less than 1 in 1,000, but it is a thing. It does happen. We don't consider that a barrier to actually trying to figure out what is in a nodule that might be cancerous, right? So yes, but is it theoretically possible? Yes. Is it going to mean that the cancer spreads all over your body and kills you? No, right? So I think that's an important thing. What was the other part? If it's low risk, is there harm in doing a biopsy?
Yeah.
Yeah, I mean, the only issue is that the train leaves the station. So once you start down that pathway, you have to just understand what you're committing to. And I think at the beginning, Anna talked about how there's a number of different outcomes that can come out of a needle biopsy, and then that will lead to another series of decisions. So just being aware of the downstream events, I think, is the important thing.
Yeah, exactly. I mean, folks often ask this, and I tell them, well, if I do a biopsy, I might get a I don't know answer.
Yeah.
That's hard to stop, right? I go, good news, I don't know. Come see me next year. No, that takes you to another biopsy or to a surgery, or yeah. I mean, so you just gotta. It's an individual decision. I push back a little bit so that people understand with me. Let's do this. Last words of wisdom. We got like 2 minutes, 30 seconds apiece. Last thoughts on this topic, that because nobody's going to remember anything in the last 59 minutes. What do you want people to remember? Louise and then Anna. Louise?
You don't have to move quickly if someone tells you you have a low risk thyroid cancer. You have time to get opinions and make decisions.
Awesome. Anna?
Yes, and echoing that, and if you get the information you need from the healthcare provider or whatever sources you can, and just it is important that you're allow yourself sort of to be involved in that decision making, because ultimately it's your neck.
Yeah, that's you guys grabbed exactly what I was going to do. I often say, slow down, get some more advice, take some time. This is papillary cancer, not to minimize it. I get it. Having a little cancer is like being a little bit pregnant. I know you either are or you're not. I get that. But this is one that you do have time to get second opinions and make sure that we're doing in the right direction. Roberta, Abby, I'll turn it over to you guys because I think we're right at the end.
Yep. So I wanted to thank the 3 of you for this presentation. I think it's been really helpful. I think, the low risk category is something that really kind of scares some people. So I think that this was really wonderful. So thank you for your time today. And it's very informative. So thank you.
Thanks for having us.
Yeah, thank you.
guys. Thanks, guys.
Bye.